So we have Dr. Anuradha, who is a localite here of Kolkata. She'll be talking about how to refract a child and prescribe glasses. So that's a very important thing when we deal a child for pediatric opthal. Dr. Anuradha, over to you.
Thank you, sir, for this opportunity. And please give the slides on the main screen. Thank you. So I would be talking on the most important topic which we face every day in our pediatric clinics and in our general clinic. So I would be going through some pertinent points. Uh, I have no financial interest, and points to ponder is how to make the child comfortable, how to do the cycloplegia and the dilated autorefraction, whether it is good or not, how to do a good retinoscopy, post-mydriatic test, and optimal correction, whether should be undercorrect, overcorrect, and some special situations. So how to make a child comfortable? The first and foremost thing is we should have a smiling face and child-friendly environment. Allow the mother to take the child in the lap, talk to the parents for first few minutes, use some cartoons or puppets, make friends with the child before going in and doing the retinoscopy or putting the drops. In infants, maybe sleeping child is very helpful. Cycloplegia, we know that cyclopentolate, we need to know some side effects before putting those drops routinely into the eye, like cyclopentolate may have acute psychosis in some cases. Atropine has to be avoided in history of Down syndrome or convulsions. Humatropine can be given in most of the cases, and tropicamide and humatropine, in these cases, we should know for allergic reactions. Dilated autorefraction. This is only giving us an estimate. It helps to tell the parents, okay, look, your child has some power, but it doesn't give you the actual power. The actual power should come from a retinoscopy. The undilated AR should never be done because it is fallacious, because child has a very strong accommodation and it will give us a false high values. How to do a good retinoscopy? It should be a dark room, calm child. Distance, you have to give an interesting target, maybe a cartoon or some videos. Sleeping infant, again, is a helpful thing. Well-dilated pupil with good cycloplegia. Wait for 40-45 minutes to get a good cycloplegia. And a proper documentation of the cycloplegic retinoscopy with working distance should be noted. Many a times what happens is when it is a small child, you tend to go near, so the working distance reduces. That should be kept in mind. Post-mydriatic test, it is required when you are giving the glasses for the first time. For children, when you do a fine-tuning of your with a subjective refraction. For the hyperopes, if the child is not symptomatic, then you would like to give a minimum power if required. Reaching the sweet point, so we have to give the minus power, which gives the best refraction, best visual acuity, and doesn't compromise on the, doesn't overcorrect the patient. In cases of accommodative esotropia, atropine is our final point, and in amblyopia, we have to think. So there is a general rule for isometropia. You have to correct the child if the child is less than 1 year and the myopia is more than -5 diopter. As the child grows up, your threshold also reduces. For hyperope, again, a child more than 6 diopter has to be corrected if the patient is asymptomatic. And as the child grows up, you have to correct accordingly. Hyperopia with esotropia, again our threshold will reduce for giving glasses. Once the child is less than 1 year, 2.5 or more has to be corrected. 1 to 2 years give +2 diopter, or 2 to 3 years you start correcting once the child is more than 1.5 diopter. Astigmatism, again 2.5 or more has to be corrected. If the child is 4 years and above, then you have to correct if it is more than 1.5 diopter, or if the patient is symptomatic. When you are anisometropic, then you have to correct earlier. So it is the threshold reduces more than -4 diopter in less than 1 year. In hyperope, it is more than 2.5 diopter, and in astigmatism, again, it is more than 2.5 diopter. So we will go through some situations. I would like to know their answer, but I think there is no mic for the audience. The child has come for a routine examination at the age of 3 years, and the LIA symbol shows that both the eyes are 3 by 4.8. The retinoscopy shows a working power of 3 diopter and 3.5 diopter. What would you like to do? So like most of the patients, you would just watch the patient because the patient is asymptomatic, he doesn't have esotropia, and the vision is fairly good. Situation 2, same with asthenopic symptoms. So the age is 5 years and the child has started formal schooling. Would you like to comment, sir? It
Switch on them,
comes
switch
to
on them.
around, in Snellen's acuity, it will come as 612 or 6 by 7.5.
See, personally, I would give them a low hypermetropic correction, maybe +1 in the right and +1.5 in the left.
Minimum
something
that we
like
can
Yeah, exactly.
Take up. Okay. Sir, any other views?
I think whenever, it's more than 2 or 3, I would just suggest the parents that this is that kind of reflective error where the child can develop intermittent esotropia or an accommodative esotropia. So maybe I would be a little on the side of, counseling the parents that the child may need glasses, and if they discover any kind of intermittent esotropia, then we should prescribe the glasses. Because 2 to 6, you have this issue of developing intermittent esotropia.
Yes. So going to the next situation, it is a routine examination. The child age is 5 years. The right eye, the vision is 6 by 12. The left eye is 6 by 6. When we do retinoscopy, there is plus 5.5 diopter spherical with a -2 cylinder in the right eye, and the left eye has plus 5 diopter with a -0.75 cylinder. So going from the retinoscopy, the astigmatism seems to be the problem. So giving the minimum plus with a full correction for astigmatism would be the way forward with exercises. Situation 4, sudden squinting. We all have these patients in our clinic, and dilated retinoscopy with CTC shows a 3 diopter. So what first you need to do is a atropine refraction and see, because this +3 may be 5 or 6, and you have to correct the whole. And once squinting is for near, even after correcting for distance, do you give it on the first go or do you give bifocals later? That would be my question.
I think we can observe with the first time by giving a monofocal, and then next visit, if it is persisting, then go for a bifocal.
Yeah, I think the same here. Like, just give him a chance with the monofocals, because bifocals, if you give, sometimes they're difficult to wean off and they are awkward for a child,
And the child doesn't like.
Child may still agree, but the parents don't like it.
In follow-up, patients like this, so you give them the glasses, the hyperopic glasses, and they're straight at distance, you're implying,
yes.
but they're still crossing at near.
Yeah.
At a follow-up visit, some people will trial them with +3 glasses
Yes.
in the office to determine what happens to that near angle. And if you add the additional 3 over the top of their glasses, we may want to know if their stereopsis gets better, what the alignment angle at near gets better. But even in those situations, it's not clear whether the best choice is to give them bifocals or not. And there is some evidence in the research in articles fairly recently that have suggested if you look at those 2 groups, even though they look straighter at distance and near in glasses with a bifocal, that there is some evidence that would suggest that giving them a bifocal doesn't always help the outcome. And some people question whether it could take away strabismus surgery results long term. And so I think it's an area that we still are studying. Either option I think is reasonable, but for me, the more that I see the addition of a bifocal in the office later helping their near alignment or stereopsis, the more I would add in the bifocal. And the less I see it helping over the top of the +3s, the more I might counsel family to watch it. That's my approach.
Yeah, I think that's really key, and what Dr. Bothon has said. If you're saying this is a convergence excess esotropia, true convergence excess, you have to show in the office that with the +3 or whatever, you make them straight for near, because if you don't, there's no point. There really is no. You have to give them stereo for near, and then you prescribe an executive style, pupil bisecting bifocal, and then they do very well.
Thank you, sir. So other thing which we are always encountering in our clinic is a progressive myopia with more than 0.5 diopter change in a year for a 5-year-old child. So what to do next? So we do have myopia control glasses and atropine for us. And the last one, recent history of blurring of vision, 13-year-old child with very high astigmatism, irregular axis. So we should rule out keratoconus.